This was a wonderful talk. Now we will be moving to the question answer session and panel discussion. All the panelists, please unmute your mics as well as your pictures. Uh, so So there are a few questions from the audience that I will be putting up to the panel of discussants. First question is for Professor Balkis Suleiman. Everybody knows that you are expert in cytopathology and you have lots of experience in especially thyroid cytopathology. What is the incidence of B3 lesions in your practice?
What is the, excuse me, can you repeat the question, please?
What is the incidence of B3 lesions in your practice?
Well, I have actually not calculated the statistics, but we do try to keep it to the minimum. I wouldn't say 10%, maybe slightly more than 10%. Aim should be not more than 10%. We try our best, but there are times when we can't label it as suspicious of malignancy or just leave it as it is benign. So we have to go for this category 3. It's a difficult decision. It's not easy. It's it takes time to look at the slides repeatedly, and then we also take help of clot histology if available. Prepare clot from the aspirated material and process it like a histological section. I try my best that I keep it as low as possible.
I think.
Okay, and one of the pathologists has asked the question, okay, how do you differentiate between B3 and B4 lesions? How difficult it is to differentiate between B3 and B4 ones?
Well, actually B4, Bethesda 4 is also considered to be as ATP of undetermined significance category, in the sense I did not, in my discussion, I did cut that part, considering that I have to stick to less than 20 minutes. There are few features which do help us, that if the aspirate is very cellular and there is nuclear overlapping, there are many micro follicles, and there is some hyperchromasia, and then nuclear border irregularities, colloid is scanty, then we go for that it is possibly follicular neoplasm or suspicious of follicular neoplasm. But as you must have noticed in my presentation, that at times you reported, one reports is at OS plus category 3, and histologically it turns out to be either adenomatoid nodule in a multinodular goiter or an follicular adenoma. So differentiation between these two very difficult on cytological examination alone. But again, if the patient is subjected to lobectomy, depending upon so many factors, it's not only the FNA findings, it's the clinical presentation, patient symptoms, patient's own choice, and then, of course, final decision between patient and the surgeon. OS-FLOS and category 3 and 4 can be together considered as undetermined.
Okay, let me bring Professor Haja Azim in this discussion. What is your opinion about B3 lesions and how do you deal with that?
I think this Bethesda 3 is very much confusing for the surgeons and as well as for the patients, because the incidence of the malignancy varies from 5 to 15%. My daughter-in-law is studying Cleveland Clinic, and she is doing this fellowship in cytology in Cleveland Clinic, and she says now the incidence of these atypical cells of unknown region is very much increasing. And they especially look at those cytopathologists who read more or you who says that this is a Bethesda 3 because this incident, as Madam said, goes on decreasing with the time. But regarding the Bethesda 4, it is a very clear-cut message that either you will have a malignancy, 30%, which is quite a big number, or you will, if you have a malignancy, then answer is you have to go with total thyroidectomy. But एटिपिकल सेल्फ जो है उसमें थोड़ा सा हमें रेजर्वेशन है कि इसका इंसिडेंस कम होना चाहिए थोड़ा सा, ताकि यहाँ तो अपनी लोबेक्टमी करें लेकिन उसके बावजूद भी मरीज कहते हैं कि जी अब दोबारा ऑपरेशन करना पड़ गया, क्योंकि बेथेस्डा 4 में हम क्लियर कट कह देते हैं कि बिकॉज द बॉल लाइज इन द कोर्ट ऑफ पेशेंट्स, they want to have a lobectomy, okay, they want to have a total thyroidectomy, okay, especially when the lesion is more than 4 centimeters. But for 3 is very difficult to convince the patient on that guideline.
Okay, okay. Let me bring Professor Sania Shuja in this discussion now. What is the role of flow cytometry in deciding the three lesions? Is there any specific role, or it is still under trial? And what will be the future of this strategy based on the flow cytometry? Please unmute yourself. We are not listening to you. Please unmute yourself.
Well, flow cytometry would be for lymphoproliferative disorders, not for thyroid in the sense of follicular lesions of the thyroid.
Okay, okay. Well, let me bring.
Can you? Okay, good. So sorry, I was muted. Thank you, Dr. Bilkis, for answering this. Yes, yeah, because
Yes,
you
not
do for
worry.
lymphoid markers, of course.
Okay. Can you please elaborate on Professor Sani? This question is for Professor Sani. I mean, is molecular profiling available in Pakistan? And if it was available, then what would be the cost?
Sorry, if it was available, then what?
What would be the expected cost of it?
Well,
it's very expensive.
I don't think it's available as yet, as far as I have the knowledge. But these tests, by the day, they do get cheaper, Now, the thing is, how are you going to apply these tests? For example, for BRAF mutation, it kind of is not going to be helpful to determine in a singular case whether this is neoplastic, or not, because it has, when it is positive, yes, it has a high specificity, but it doesn't have a very good sensitivity, because not all tumors are going to be BRAF positive. So only those tumors are going to be informative for doing BRAF, which have a BRAF mutation. But having negative BRAF, being negative for BRAF mutation doesn't help you to decide whether it's a tumor or not. So they do have also applicability, which is limited, However, gene profiling could be more helpful. I mean, just the way I gave you an example about the new genes that they have discovered through gene profiling, and they think that BRAF mutation positive and BRAF mutation negative tumors are two distinct type of tumor groups, and they have their own specific gene profile. That could be helpful in future. But these things are, currently basically research stuff, and they don't have widespread clinical utility.
Okay, this question is to management of the hypertension in the perioperative period when we are dealing with pheochromocytoma for Dr. Asif Hussain. Can you please elaborate on the role of peripheral calcium channel blockers? Because many of the people don't know that there is a significant role of peripheral calcium channel blockers. We use it very routinely in our practice, apart from the alpha blockers. The central peripheral as well as central calcium channel blockers can be quite helpful in controlling the patients and preparing for pheochromocytoma.
Yes, certainly when we are dealing with the cases of the pheochromocytoma, most of the evidence we have is with the alpha-1 blockers. The calcium channel blockers in most of the guidelines, they are recommended for either either as add-on therapy when alpha-1 blockers and beta blockers are not enough, or we use them as monotherapy if the patient has either mild hypertension or patient is biochemically active but clinically silent. So these are the two main guidelines when we use calcium channel blockers. Out of the calcium channel blockers, there are two types of calcium channel blockers. One is vascular and other is the cardiac one. So the vascular calcium channel blockers are more helpful for blood pressure purpose. Example is there are only two cardiac, rest all are vascular. So V for verapamil and V for ventricle. So verapamil is cardiac, diltiazem is dual. It works on heart and arteries. Rest all the calcium channel blockers are arteriodilators. So nifedipine, amlodipine, they all can be used, but mostly because amlodipine is but longer acting, it gives a better effect. Nifedipine is very strong and that can be used as well. So mainly the recommended one are the vascular one, unless you can't use beta blocker for some cardiac reasons.
Okay, well, let me expand on it and let me involve Professor Khwaja Azim on it. What is your experience about the peripheral as well as central calcium channel blockers in the preparation of a patient with pheochromocytoma?
I think we are doing this pheochromocytoma for last 30 years. First before in Mayo Hospital, now we are doing in the Shalamar Hospital. Our experience to prepare the patient is use of one is the alpha blockers, very effective. No doubt there is a drop postal hypotension because you block the alpha receptors. There is a immense vasodilatation and you can deplete the blood volume by hypotension and tachycardia. And the second important thing, we don't are the believer, we don't use it. Actually, in fact, we are not the believer in using the beta blockers, except when the patient has got a tachyarrhythmia, when the pulse rate goes beyond 140, then we use the beta blockers. The reason behind is if you use a beta blocker, sometimes they mask the symptoms during the operation intraoperatively, and the signs of hypotension or tachycardia, they are masked. So we always use a combination of alpha blockers, peripheral calcium channel blocker like amlodipine, and these central calcium channel blockers. That central calcium channel blocker, we can able to control the heart rate because it improves the delays the conduction of impulses from atrial to ventricle. At the same time, it also improves the circulation to the coronaries. So we are using this one combination of alpha blockers with calcium channel blockers, both is central and as well as the peripheral calcium channel blockers with the lot of fluids which contain sodium.
That's
We
great.
advise the patient to have a lot of sodium in their diet, so there will be the only cation which is going to hold the fluid in the intravascular compartment is sodium. So if you increase the sodium in the diet, you can automatically expand the blood volume with the blocker of the alpha receptors. This blockers control the heart rate. So we always use this when we have no experience of using the beta blocker, and rarely sometimes on the operation table there is a need of beta blockers. Because
That's great.
if you properly hydrate the patient and well block the receptors, alpha receptors, and also control the heart rate through the central calcium blockers with good coronary circulation, I think we don't have any problem. It looks like that we are operating on a hernia or a cholecystectomy. If you well block and well hydrate the patient at least 3 to 4 weeks, and I think you will not have a problem.
Okay, this is for Dr. Sanya Shujar. Would you like to comment on this particular section? Please unmute yourself.
Pardon me?
Would you like to comment on the session?
Any comment on this session?
The entire, it was wonderful. It was a great session. I'm sorry I missed the earlier part because, I had to, was busy. Today was a very busy day at work as well, but it was wonderful. I must say thank you so much for putting it together. I mean, I'm sure people must have also learned a lot, from this session. And the wonderful comments and feedback is always, very, very important. Well, thank you so much.
This is for Asif Hussain. How is the situation of COVID in Australia at the moment?
We are enjoying freedom. We're enjoying freedom. We don't have COVID in Australia and New Zealand anymore.
Oh, wow.
You don't have COVID in Australia?
You are not better than Trump.
Yeah. You all are invited to visit me in Melbourne.
Okay. Let us all be vaccinated first, and hopefully.
Yeah.
Do you have any comments about this particular session, or any advice or comment or anything for the audience? Asif
Are you
Hussain.
asking me? Yeah.
Yes.
So I think it's a wonderful effort, and probably one of its own type, a new thing in the town, which Shalamar has taken the lead. And I'm all very much admirer of Professor Hajazim. I was intern when he was professor in Mayo Hospital. So with Professor in So मुझे इनकी बड़ी बातें याद हैं, कभी इनसे मिलेंगे तो बात करेंगे. मेलबर्न है तो be my guest please.
Thank you.
Yeah, that's great. Okay, Professor Balkis Suman, please unmute yourself. We can't listen to you. Please unmute yourself.
Okay, sorry. हाँ, ख्वाजा साहब से एक बात करनी है कि हम बहुत कोशिश करते हैं कि आपको एक डेफिनेटिव रिपोर्ट दें, बिनाइन है, malignant है, सस्पिशियस ऑफ malignancy है, लेकिन एक ग्रुप आता है उसके बीच में जो वर्ल्ड वाइड नोन है, उसमें किसी की वो चालाकी होशियारी नहीं चलती. वहाँ हमें आपको मैसेज पास करनी पड़ती है कि भाई हम इस फर्दर आपको देखना पड़ेगा. When we have these gene mapping, pharma testing and molecular testing, फिर तो लाइफ आसान हो जाएगी, पर वो अभी हमारी नहीं है. तो हमें जो कुछ है उससे बेहतरीन रिजल्ट निकालने पड़ते.
लेकिन मैडम मुझे ये बताएं कि ये जो जेनेटिक स्क्रीनिंग है और जो भी वो कर रहे हैं, इसके अंदर भी तो प्रिडिक्टेबिलिटी है ना, इतना महंगा टेस्ट कराने के बावजूद भी देयर इज नो श्योरिटी.
अभी है ही नहीं. अभी हमारे पास
प्रेडिक्शन है कि होगा,
जब आएगा शायद कंपटीशन में और बन के ज्यादा के मतलब कंपनीज इन्वॉल्व हो गई तो प्राइस कम हो जाए, जैसे बाकी भी पीसीआर वगैरह की हुई, तो लाइफ आसान हो जाएगी, बहुत आसान हो जाएगी, आपकी भी हमारी भी, लेकिन मरीज की भी. लेकिन अब जो कुछ है, let's make most of it. Try our best. We try.
We are very thankful to Professor Balkis Suleiman and likewise Professor Sania Shuja. The reason being that we are able to have good reports. I mean, there are very few cytopathologists. We are lucky. Dependably, and there are very few histopathologists who can report dependably. So we are very thankful to you two people especially, because our practice mainly relies on your efforts.
Absolutely.
And we are all very thankful to you. So let me thank all of the participants as well as the panel of discussions as well as the audience. Thank you for your patient listening, and it was a wonderful session, and we all thank you. Thank you very much.
Thank you.
Thank you for letting us be part of your session. Thank you.
Thank you very much.
माइक बंद कर दो.